that we begin this seminar. All right, so welcome to this online seminar, which is regular activities in the Department of Rehabilitation Sciences. Now, for the past year, we have suspended a number of seminars because of the pandemic. And thanks to the arrangement of Professor David Mann, and who is the DLC chair of our department, and we are now opening the online seminar again. And this is in line with the fact that we have recruited quite a number of new staff. And I know that from the last week, we have already begun the first seminar, which was delivered by our research assistant professor. So today, we are very happy that we have another research assistant professor, Dr. Jessie Lin. So I will be introducing her briefly, and so that all the audience will have a basic understanding of the background of our speaker today. Because I'm quite sure that other than our academic staff and also students, we have quite a number of clinicians joining from external parties. All right, so Dr. Jessie Lin received her degree in clinical medicine from the Medical Knowledge of Zhejiang University in mainland China, and also a master's degree in Science of the Neurocognitive Psychology at LMU in Germany. And also she received the PhD degree from the Department of Psychiatry in Hong Kong U. During her PhD study, she was among the first to study the effects of mind-body intervention and also aerobic exercise on neurocognition in patients with early psychosis using neuroimaging techniques. And this is to find interventions that may help people with psychosis to improve memory and attention, and at the same time to ameliorate their clinical symptoms without taking medication. And his current research is on clinical impacts and to find out neuromechanisms of psychosocial and mind-body exercise intervention on cognitive function in patients with severe mental illness and also mood disorder in women. And today, we are very happy that Jessie will be giving a presentation with the title, Non-Pharmacological Interventions for Cognition and Emotion in Psychiatric Disorders. All right, so that's all for my introduction. So I will be passing the time to Dr. Jessie Lin, please.
Thank you so much, Professor Chen, for the kind introduction. So hello, everybody. I'm so excited to be here to meet you online. So it's my first time to present my research areas in RS. And yeah, as Professor Chen introduced just now, yeah, so my background including medicine and also the neurocognitive psychology and the psychiatry. So my research interests focus on the cognitive impairment and also the mood symptoms in patients with psychiatric disorder. Okay, so before starting my presentation, I would like to thank some people and also the parties which are related to my presentation. So first, I would like to thank Professor Chen and also the Department of RS at PolyU to provide me the opportunity here to share with you my research. And also, I would like to thank my previous supervisor, Professor Eric Chen, and also PS team at Hong Kong U, also the collaborators for the imaging technology in Canada and also at CU Hong Kong. And also, I would like to thank the funding parties, including RGC and also the Hong Kong U internal grants. Okay, so this is the outline for my presentation today. So we're going to talk about some cognitive function in psychosis because my study focuses on the cognitive function and also the emotional symptoms. And then I will point out the exercise intervention and the mindfulness-based intervention in today's presentation, and share with you some findings, including the clinical finding and also the imaging findings. And finally, if there is still some time, I would like to share with you the community implementation, and we will have some discussion in this field. Okay, so first, I would like to start with cognitive function. So actually, cognitive function is very important, not only for the patients in psychiatry, but also for us, the healthy people. So cognitive function actually is a very comprehensive concept, which includes very basic cognitive function like attention, memory, and it also includes some advanced cognitive function like executive function, and also includes the languages, perception, and also the social interaction. So this is I'm going to talk about in psychiatric disorders. So okay, so now let's start in psychosis. So psychosis actually refers to a set of symptoms. So it's a syndrome, including the symptom of hallucinations, delusions, and disorganized thoughts and speech. And also in psychosis, cognitive impairments, especially the memory and attention, core features for this group of patients. Cognitive impairments can start very early, just predates illness onset. So before the onset of psychosis symptom, the patients already show some cognitive impairment. And also research found in the medication naive patients, also the cognitive impairments already appeared. So these impairments have very severe consequences in the patient's daily functioning and also the long-term outcomes. And in the DSM-5, cognitive dysfunction has been proposed to be considered as one of the diagnostic criteria. So from here, we can see that actually cognitive function is very important for the long-term rehabilitation in schizophrenia psychosis patients. Okay, so here are some evidences that we found in the schizophrenia patients that the deficits of cognitive function are mainly in working and episodic memory. So, and more evidence have been shown in the post-mortem data, and the hippocampal reduction. So compared to, here is the normal, the healthy people hippocampus, and here is the patient, schizophrenia patients hippocampus. So it's very clear that the hippocampal volume reduced significantly in the schizophrenia patient. And here is the evidence of hippocampal volume reduction related to the memory dysfunction. So we can see from here, here is the hippocampal volume in imaging. And here is the correlation with the VTMT. VTMT is a verbal memory test. So this is very correlated with the functions. And we know that schizophrenia patients have significant dysfunction in memory, attention, and the soul. What can we do for this? Or what can we do to help them, to treat them? So here is a rough picture of current treatment for the cognitive function in psychosis. So in Hong Kong, the prevalence of psychosis is around 2.5%, but only half of them receiving help. And this is a, so first line treatment is antipsychotic. But we found that antipsychotics had minimal effect on cognitive impairment and also the functioning. So antipsychotics are very effective for the psychotic symptoms like hallucinations or delusions. After 4 weeks medication, and the symptom can disappear. But for cognitive impairment and also the functioning, we found it's something is difficult with antipsychotic treatment. So another problem is the poor medication adherence we found in the patient. Because the medication has the significant side effects like obesity or fatigue for the patient. So the patient is not willing to take the medication. So as I titled here is non-pharmacological interventions addressing the cognitive impairment have been explored already for decades. So non-pharmacological intervention is a very big concept. And nowadays we use most often to help the cognitive function is the CRT, the cognitive remediation therapy. But we found that CRT, yes, it's effective for the cognitive function for the patients. However, it is also very difficult to generalize in daily life due to a very high resource consuming. So we need therapists, well-trained therapists or qualified therapists, and we need the computers. We need very strict schedule to give the patients intervention. And also there are many other non-pharmacological interventions we use in clinic, but targeting the cognitive impairment, CRT, is the most widely researched approach. And so far there is no standard or widely recommended non-pharmacological intervention with very good generalization and cost effectiveness in the clinic. So this is the background for us to explore some very simple and cost-effective intervention for the patients. So first evidence actually comes from the animals. So we found in the animal study, exercise can improve their performance, so-called the cognitive performance, including the maze test, and also from the biological side, we can see that exercise can enhance the number of cells in the animal. And also physical activity can regulate the neurogenesis of the hippocampus. So these are all evidence from the animal. So, okay, so, and then we think that, so animal doing exercise, so can we use exercise intervention for human being? And to improve their neurogenesis and to improve their synapse function. So does it work for it? And then, so first study, which have been done already several years ago. So we have an RCT design study in psychosis patients and randomize them into 3 groups. So yoga, this is a mind-body exercise, and aerobic exercise. So it's pure aerobic exercise, and a group of weightless control. And the intervention duration was 12 weeks. So after 12 weeks, we measure them again, and we follow up them for 18 months, and then measure them again. And the imaging measure was used only at baseline and 12 weeks, not the long-term follow-up time point. Okay, so what we did to the patient. So 3 groups. These were all female patients with psychosis. So at that time, there was a study in Germany, and they tested the aerobic exercise in male patients with schizophrenia, very chronic schizophrenia. And they found that hippocampal volume increased after the aerobic exercise intervention. And to compare with this study, we use female patients. This is one reason we select female patients, to have a gender comparison with the study in Germany. And the other reason is that in Hong Kong or in Asia, yoga as a mind-body exercise is much more popular in female than in male. So that's why we want to compare 2 different types of exercise on the cognitive function. So for the aerobic exercise group, we use cycling and the treadmill. So cycling is not the bike, it's a stationary cycling. So you usually in the gym, you can see it's stationary cycling. Yeah, and for treadmill, we just ask the patient to walk. So it's not running, it's walking. 3 times per week with a coach, and for 12 weeks. And for yoga group, we use Hatha yoga. So you may know that there are many types of yoga, and we select Hatha yoga because it's the typical yoga style, and it compromises breathing, posture, and also relaxation. So 3 components there. And the same frequency, same duration. And the control group is waiting list at that time. And all the subjects will be provided either an aerobic exercise program or yoga intervention after their waiting time. Okay, so this is a whole study view. Okay, so now let's see what we got. So we found that actually both types of exercise, so we say aerobic exercise and the yoga, improved the verbal memory and the working memory very significantly. So you can see encoding and the long-term memory, this is a verbal memory tested by the Hong Kong Learning List test. So it's a local developed measurement by CU Hong Kong. So encoding, we found these 2 groups, these 2 intervention groups, yoga and aerobics exercise, improved very significantly. So same in for long-term memory. And here are 3 time points. So baseline 12 weeks and 18 months. And we found that from baseline to 12 weeks, so increase very quickly, and then they can maintain it. But at the same time, you may notice that for control group, we also found that from baseline to 12 weeks, actually there is no significant changes. But from 12 weeks to 18 months, there is an increase, but not statistically significant. So for this part, we guess maybe because the control group actually they were provided exercise program after their waiting. Okay, so so we think that maybe this reason could be the explanation to for the increases during this period. Okay, and then for working memory, so the same for the intervention groups. But for attention, which is measured by the letter cancellation test, we only found statistical significance in yoga group, but not in aerobic exercise group. Okay, so here is a difference between two types of exercise. Okay, so now we go to the psychotic and the depressive symptoms, which we measure use PANSS total score and also the CDS total score. Oh, again, both interventions were effective to reduce the symptoms. Both yoga and aerobic exercise, you can see the line decrease, yeah. And then the effect actually still maintained through the 18 months after the intervention. Okay, so the similar pattern found in the control, you see that from 12 weeks to 18 months. So the clinical symptom also reduced. Okay, so, and besides this, we also found the drug attitudes also improved in the aerobic exercise. And drug attitudes refer to the patient's model of health. So this is one subscore of drug attitudes measured using the drug attitude index, which is was correlated with the improvements in cognitive function and the clinical symptom. Okay, so some imaging findings here. So first, we also measure the hippocampal volume in both intervention groups, but only found the increases in hippocampus in the aerobic exercise group, but not yoga group. Okay, so this is the structure. And then we look into the Fmri data. So it's the resting Fmri data. So we did an ALFF analysis. This is a, as we call the fluctuation of the brain at resting state. So we found a decreased ALFF in the precuneus and the parohippocampus in yoga group. So we only found the decreased and the statistically significant decrease of Fmri data in yoga group, but not in aerobic exercise group. And this decrease correlated with the reduction of psychotic symptoms. So precuneus, you may aware that precuneus is part of the default mode network. So default mode network is a neural network that related to self perception and also to the attention. And precuneus is the key component of the network. So that we think that yoga may decrease the neural activity in the patients, and then also decrease the psychotic symptom like hallucination or delusion. Yeah, so this is why we found the correlation between the psychotic symptom reduction and also the decreased signal in precuneus. This is one analysis of Fmri, and then we did another analysis for the MRI data. Again, it's functional MRI. And we use the connectivity classification analysis. So this is to, so the whole brain we will select 5% of the features we found the most active. And then we did a connectivity analysis to see that if these features were interacted together. And we found 3 patterns. So this is a neural network like connectivity net pattern. And so the so here is the yoga group compared to the control group. So we found a pattern mainly lying in the connection linking the medial prefrontal and the posterior cingulate cortex. So here the medial prefrontal to the posterior thing. So you can see here, this is one connectivity, okay? And the other connectivity is linking precentral gyrus and the temporal. So precentral gyrus and the temporal. Okay, so this is for yoga group. And again, the medial prefrontal to posterior cingulate cortex is a major pathway in the DMN, default mode network. So the B, this pattern is compare yoga from aerobic exercise. Okay, so when we compare 2 different types of the exercise, we found somehow overlapping pattern. So which means that yoga and aerobic exercises, somehow they have very similar effect, but there is a slight shift to the right hemisphere. Okay, so which show that compare yoga and aerobic exercise. So the aerobic exercise affects more on the right hemisphere, and the area also including frontal to parietal, frontal to temporal. Okay, so let's see. C is we did the compare between aerobic exercise and the control. So you can see that here is more clean. So which means that there is less features compared to what we see in yoga group. So when we compare yoga and the control, we see some network. So you can see many dots. But when we compare the aerobic exercise and the control, there is less connectivity. Okay, so so this analysis is just have been done recently, and we're still working on the how to interpret the results. So so overview is we can see that yoga changed the neural network more, and aerobic exercise seems change the brain structure more. Okay, so this is from the existing what we got in this study. So some implication I will mention again at the end. Okay, so here is the exercise and the yoga, different type of intervention exercise for the psychosis patient. So we have a very short summary for study 1. Is that actually both types, we found both types of exercise can improve the verbal memory and also the working memory. And we also observed that these effects can maintain at 1.5 years. And for clinical symptoms, psychotic symptoms, depression, both types of exercise works very well. And from neuroimaging data, we observed that there were some differences in aerobic exercise and yoga. Okay, so seems that aerobic exercise changed more the brain structure, while yoga changed more the brain function. Okay, so here is the second study. So I'm going to talk about the mindfulness-based intervention. Okay, so why we got this? Because we found that depressed patients usually had worse functioning, poor quality of life, and the lower level of self-efficacy. And also, when we test the cognitive function, we usually do the cognitive test. So cognitive test, we call it objective cognitive tests. It's objective. And we also measure the patients for the subjective cognitive impairment. So which means that we measure how the patients feel about their cognitive impairments. So you know that sometimes the patient will complain to you that he has a very bad memory, but actually his performance is not so bad for the cognitive tests. So this is what we interest that to see subjective cognitive impairment and objective cognitive dysfunction. So what's the relation between these two aspects? And we found that we analyzed the data in the study I mentioned before, and we found that actually depressive symptom is very important for the subjective cognitive impairments. And the subjective cognitive impairments was not correlated with any of the objective cognitive tests. So which means that the patients subjectively feel that he or she has a very bad memory, very bad attention, but actually the test performance is quite good. And we observe that those patients who complain about the very poor cognitive function usually has very severe depression. So this is what we observe from these patients. Okay, so the implication is that treatment should not only focus on the symptom or cognitive performance, but also we should take care of the moods like depression, anxiety, and also the subjective feeling of the patients. Okay, so for this reason, we try to reduce the depressive symptom in the patients. And we selected mindfulness-based intervention. So again, mindfulness-based intervention is a very hot topic nowadays. Yeah. And we know that there are standard mindfulness-based interventions we call MBCT and BSR. And what we used in psychosis patient is self-developed and we try to make it simple. So again, so we know that for mindfulness intervention, the facilitator need to be qualified. And as I know, it's a master program, like 2 years full-time master program to train a qualified mindfulness therapist. Yeah, so again, so it's very resource consuming if we do MBCT and BSR. So first, I would like to very shortly introduce mindfulness. Maybe some of you are very familiar with that. Actually, it's from the Buddhism, yeah. But the definition is quite simple. I would like to use the John Kabat-Zinn definition of mindfulness. It's just paying attention in a particular way, which means that paying attention on purpose and in the present moment, now and here, present moment, and non-judgmentally. So there are three key components of mindfulness intervention. One is attention, and the second is now and here is present moment. So you focus now and here. Don't look back, don't look into the future. And without any judgment. So non-judgmentally is the third component. Okay, so mindfulness intervention is so-called the third wave of psychological intervention, and it has been found to be effective for many psychological problems, including stress, anxiety, depression, and also in some disorders. And the meta-analysis found that significant reductions in negative and affective symptoms in patients with different psychotic disorders, and also can increase the functioning and the quality of life. And the meta-analysis mentioned that mindfulness intervention has a lower dropout rate than CBT. Okay, so the first research gap is that there is no insufficient support from RCTs on the patient with early psychosis. So, and we know that the very formal program of mindfulness like MBCT and BSR are quite complicated, and facilitators may need intensive training to get the qualification. Okay, so what did we do? We have developed a very simple program. It's a low-intensity mindfulness-based program. It's only 7 weeks for the psychosis, based on the psychosis patient's characteristics, which is, so one of the side effects of mindfulness intervention is that there are some studies reported. So mindfulness may induce the hallucination or delusion in this patient, even in healthy people. And that's why we make the mindfulness practice very short, so like 1 minute. So it's not the usual duration of mindfulness intervention. So usually for healthy people, the mindfulness intervention can be done like a practice like 20 minutes, 40, I think 45 minutes maximum. But for psychosis patients, we only do for 1 minute. So the mechanism duration is 1 minute. After 1 minute, we will break them and ask them to stop mindfulness practice and ask them for the feedback. And we actually we cut the practice into several 1 minute. So 1 minute stop, and then 1 minute again. So this is the very important thing for psychosis patients. So we did a pilot in 14 patients, and after 7 weeks, we did a pre-post comparison, and we even found a statistically significant improvements in depression. So it's very significant. The patient or the patients reported the mood symptom has been reduced, and also the mental well-being and the general psychopathology, so on the PANSS total score, and the increase in the mindfulness level. And we also did the qualitative data to qualitative questionnaire to ask the patients, and the comments suggest that the intervention was safe. So none of our participants reported any side effect or adverse event. And they were all enjoyable and had a very positive impact on mood symptoms. So very significant mood symptom effect. So based on this pilot data, and there is a big RCT now is ongoing in psychosis patient. Okay, so, and then I am thinking of another group of patients. So it's the postnatal depression, so postpartum depression, postnatal depression, or perinatal depression. So why I put attention in this group of patients, because actually postpartum depression patients, so the symptom-wise, we say clinical symptom is it's actually the same or very similar with major depression symptom, major depression patients. But just the time right after the baby birth, and the gender is female. So we know that females are more sensitive to emotional problem, and also after getting a baby. So this is a very important moment for a person. And also postpartum depression is not only related to mother. Okay, so so the mother will have impaired parenting behavior and will have lower quality of life, and for father as well, for the whole family as well, and the self-esteem. And the mothers will be at very high risk of developing long life, so lifelong and recurrent major depression. And even severe consequence is that the suicide and also the infanticide. So this is for mother, for the family. And the other consequence of PPD, we say the postpartum depression, is on the children. Okay, so there are many studies report that actually postnatal depression mother is associated with a disruption of the relationship of the mother-infant relationship, and which contributes to the delay of emotional, cognitive, also behavioral development of the children. And very few, another key point is that very few women suffering from postpartum depression received a standard or formal treatment. So as a study reported, the percentage is only 13%, 10 to 15% of women seek for help. And in Hong Kong, we didn't find the data, but from clinical observation, many mothers with the postpartum depression, we say it's not clinically diagnosed depression, but depressive symptom, they will not seek for help. Okay, so especially for not Asian women, but Chinese women, they always hide it. So first, the response to the depressive symptom, the mothers will just hide the symptom, yeah. And when they found themselves cannot cope with that, so it's out of their control, and then they will seek for help. But the system in Hong Kong is that MCHC will assess the mothers or the mothers after 6 weeks after childbirth, and if they use Edinburgh, a scale, Edinburgh postnatal depression scale, and only those women whose score is over 13 will be referred to psychiatry service. But actually, the score is above 10. We say that the woman has already have depressive symptom. Okay, so above 10. So between 10 and 13, we can say it's a very early stage of postpartum depression. And actually, in the early stage, early intervention, early treatment can make a big improvement. But during the early stage, this woman, these patients didn't have any help. Okay, so yeah, just measure them. Okay, so your score is below 30, and then, yeah, I know that some NGO provides the counseling or psychological support for this group of women, but still very few women have the sufficient support during the very early stage of the postpartum depression. Okay, so what we did. So this is quite new data, because I have just completed this RCT and not yet publicated. And so we have 70 participants who were diagnosed as postpartum depression. So it's clinical diagnosed patients. Okay, so we randomized them into two groups. One is the mindfulness-based intervention revised version, and the other is psychoeducation group. So it's active control group. So let's see what happened. So it's an 8-week intervention. So finally, we got 31 in the mindfulness intervention group and 22 in the psychoeducation group. And we follow up them for 3 months. And we got total 52 patients. Okay, so first we look at the depression. So surprisingly that we found both mindfulness intervention and the psychoeducation can reduce the depression. And I also heard that in another study by my colleague, and also found the psychoeducation actually is quite good for depression. Yeah, and we can discuss later. So this is what we found. So both groups decreased, and the effect actually can maintain at 3 months. Yeah. And this is the visual motor coordination test. We use digit symbol coding test to measure the cognitive function of the mothers. And also both groups improved the visual motor coordination after 8 weeks. And these effects again can be maintained through the 3 months. So this is the first thing. Both groups, so both mindfulness intervention and the psychoeducation can improve, yes. Okay, so let's see something that psychoeducation cannot, but only mindfulness intervention is that low functioning. So we found that mindfulness actually can reduce stress. Okay, so reduce stress, and the psychoeducation cannot. This is interesting. And mindfulness improves the low functioning. So here is the low functioning measure. We use low functioning scale. It's independent living function, and also the extended social network relationship. So these two increased. So you can see that the blue line is mindfulness group, and the red line is control. Okay, we can see that after 8 weeks, the blue line increased, so control decreased a little bit, but not statistically significant. And this is the 3 months follow-up. So for the extended social network, is slightly reduced after the intervention. So it's quite clear that after the intervention, these mothers had no social activity maybe. So the score decreased, but not statistically significant. Okay, so I mean, these RCT has been completed before COVID-19. So the intervention period completed last year in September or October, and the follow-up completed in February. So it's not related to COVID-19. Yeah. And this is the mindfulness level we measure, use the FFMQ. We can see that the ability of observation increased very significantly in mindfulness group, but not in psychoeducation group. Okay, so it's obvious. Yeah. Okay, so let me make a short summary again. So this part, we talk about the mindfulness-based intervention in postpartum depression women. And we found that mindfulness intervention actually can reduce stress, depression, both, and can improve functioning and emotional well-being in postpartum depression and also in the psychotic disorder patients. And actually, psychoeducation also works for the mood symptom, but not the functioning. Okay, so yeah, neuromechanism again, underlying these effects would be very interesting to explore. And some clinical implementation can be considered really for postpartum depression women, especially in their very early stage, because doing mindfulness-based intervention, we can using online equipment and not really face-to-face. So especially during like the COVID-19 pandemic, so very critical period. And these patients, they do need some help. Even during the COVID-19, they even more need the help, but we cannot conduct face-to-face, we can conduct online. So actually I tried online mindfulness-based intervention for some people with depression, anxiety. I think the effect, there's still effect, yeah. And for me, I'm planning to do a study to investigate if there is any difference between face-to-face intervention and the online intervention. So if we found online intervention, online mindfulness intervention is the same effective as the face-to-face intervention, then maybe we can promote the online session to more population. So just briefly share with you some the community implementation. So based on the study, we developed the exercise programs for psychosis patient. We call it Fmri 10 and Fmri Yoga. Okay, so this was developed when I was in the Department of Psychiatry at Hong Kong U. So maybe some of you have already heard it. Yeah, I believe that. And also we have some press conferences using the social media to promote the evidence-based programs to the community, to the patients, to the caregivers. And for the mindfulness-based intervention, I did the knowledge exchange project to implement the intervention to the psychiatric disorders, including psychosis patient and also the depressive woman, and also some parents at high risk of mental disorder, and also to help to train the workers in NGO to sustain the program in the community. And we hope to help more people with not only with psychiatric disorder, but with mental problem or mental disorder to have a more healthy psychological or physical well-being. Yeah. Okay, so we are almost done today's presentation, and before I say thank you, I would like to share with you some implication from my research. So first is that non-pharmacological treatments, we are talking about aerobic exercise or mind-body exercise or mindfulness-based intervention, really have considerable effects on cognitive function and emotions. Okay, so this is in patients with psychiatric disorders. And we observed that long-term effects of 1.5 years. Okay, so in my study, it's 1.5 years. And I did a search before, and I only found one publication talking about 3 years follow-up of an exercise intervention for not in psychosis, but I can't remember that. Yeah, so it's the longest follow-up is 3 years. So the longer term effects of exercise in psychosis or in other psychiatric disorder so far is not clear. So how long can the effects maintain? So we are not so clear about that. And also we observe different neural patterns between the aerobic exercise and the yoga. So we observed the aerobic exercise changed more the structure, the brain structure, and the yoga may have more results in the functional data, so brain functional data. So this is very interesting, and I think worth to explore more here. Yeah. So again, another therapy, mindfulness, is also effective for both the mood symptom, also the functioning in the postpartum woman with depression in my study. And I believe that mindfulness nowadays is used for many different group population and have very positive findings in different populations. So again, this is what I'm thinking to do next or in the future is that I'm just curious, what is a specific neural or physiological mechanism underlying these interventions? So we are talking about different interventions like mind body. I know Professor Chen has many experience in Qigong, and I also heard that Tai Chi and yeah, so many kinds of mind body exercise. So will these interventions share the same neuron pattern? So this is the first I would like to ask. And which component actually of these interventions works most effectively? So we know, like for yoga, we have different components. We have breathing, we have body posture. So body posture, as I understand, body posture is the movement, the body movement, like aerobic exercise has body movement. And also yoga has relaxation, meditation. So this is different components. And I tested mindfulness in psychosis because I just put the meditation component from yoga. So mindfulness actually is a simple meditation. So I would say that. Yeah. I just put one component from yoga and to see if it works. Because compare aerobic exercise and the yoga, we found that the most different component is yoga has meditation. Yeah, right. So the second question or direction is that how do we match different types of non-pharmacological intervention with different individuals? So like, so maybe for some elderly people, we use Tai Chi or Qigong will be more feasible. And for some patients, and they prefer active active exercise. So maybe aerobic exercise will be more attractive to them. And for some patients, they don't want to do exercise at all. Maybe do mindfulness-based intervention. So this is what I, for my thinking is that how do we match? How do we develop is personal treatment we call or individualized treatment for different kinds of patients. And this is really important in clinical practice as well. Yeah, okay, so now I will say thank you for your attention, and let's discuss more maybe.
Okay, so are you finished?
Yeah.
Yeah, all right. Okay, thank you very much. Thank you very much. So I really enjoy, listening to your presentation. Now, in fact, I told my colleagues when you were doing your presentation while you are applying for the job as RAP, that the reason why I enjoy so much your presentation is that because you have done quite a number of things that I really want to do myself.
That's good.
Extending my work on Qigong to yoga, but
yeah.
because of my helpful role as the head of department here, and that is why I cannot participate and be the PI of this kind of research myself, but leave it to the young investigator like you. All right, so I think we can open up the discussion. Now, I would like to ask the first question.
Yeah, please.
And kick off the discussion. Now, I think the question I would like to ask is also the question that you would continue your investigation in the future. Now, I think you have done a very interesting job that you have found both aerobic exercise and yoga to be effective. And they have some kind of action on the brain, but in a different pathway. Now, as what you said, you summarized that aerobic exercise will be having more to do with changing the brain structure, while the yoga is on changing the brain function. So I would like to ask, have you had any speculative mechanism that may try to explain the differences?
Oh, yeah. This is a very good question, yes, and I'm thinking all the time about that. And so for my understanding is that aerobic exercise, we move the muscles. Okay, so usually like running, working, everything, so we move the muscle, and it increases the metabolic of our body. And the yoga, this is another story. So yoga, we emphasize the attention and concentration on the physical sensation. So actually in yoga, the body movement is not so active. I would say the intensity is much lower than aerobic exercise. So in yoga, the metabolic not increase so high as aerobic exercise. So this may be the reason that we observe that the blood flow increased in the brain, and the hippocampal volume increased. So I would say its main depends on the increased metabolics. And for yoga is more using the brain. So the activity of the brain or the stimulation of the neuron may be increased, but not the blood flow. So if we use the brain more, so like we stimulate the neuron, so we ask the patient to focus on the body, to sense the body, so the neuron activated continuously, and then the connectivity, so which means that the information exchange between different neurons will be improved. So that's why we observe the connectivity pattern in yoga group, but not the exercise group. But we observe the hippocampal volume increase in aerobic exercise group, but not in yoga group. This is my understanding. Yeah.
It makes sense. Now, I think we can spend more time on this very interesting issue, but I would like to leave time to the audience. So I'm quite sure that quite a number of you will like to ask questions. So if you have any questions to ask, you can raise your hand, all right, using the Zoom. And you may also write down your comments, and so that we can see and ask Jessie to answer you. So who would like to raise questions?
I think Aaron raised a question.
Yeah. So Aaron, all right. Aaron, you want to show up yourself and ask it verbally? Yeah, Aaron, where are you?
Okay, yeah, can you hear me?
You may ask directly, your colleagues.
Yeah. Thanks, Jessie, for the interesting presentation. I have a question about the postpartum depression study. So I'm just wondering whether sleep quality was assessed in your study, because I think sleep deprivation would be a very common situation for those new mothers, and I think this factor also played a role in their depression. And I'm wondering how mindfulness intervention will contribute to that.
Thank you for the question. It's a very important issue, but sorry that we didn't measure it.
Okay.
Yeah, because we focus on the symptom and the cognitive function for my previous, but absolutely, I will add this one in my next study. Thank you so much. Yeah.
Thank you.
Thank you, Dr. Jessie, for your fruitful presentation. May I ask a question?
Yeah, sure, please.
Because I hear that the yoga and mindful exercise are beneficial for the psychological condition.
Wait. Now, can I suggest that for those who are the first time to ask question, you just briefly introduce yourself. So where are you from and what is your name?
Okay. I'm Clifton, a year 4 physiotherapy student in PolyU, and I want to ask that I observed that the yoga and the mindful exercise are beneficial for the psychological patients. But if resistance training would also be one of the options, and the other less academic question would be, being a physical therapist, would studying clinical psychology be a better way, recommended pathway, if I want to focus in psychological patients? Thank you.
Okay, so let me get your first question. Resistance training, yes. Actually, I had some experience to doing resistance training for the psychosis patient as well, but we didn't have the data. But I know that because I had a review of this resistance training is also effective for the patient's depression. And some studies also reported the positive improvement in cognitive function and mainly in attention, because resistance training actually it's I think so it's more focused on the body sensation, because it's not so aerobic as we did. Yeah. So and this is a very good training for especially for the elderly people, because it's lower VO2 level. You know what I'm talking about, VO2.
Yeah, I understand.
Yeah. So it's lower fitness level, and it's very good for elderly. So usually we use it because psychosis patient, some patients are also physically physical ability is not so good, so we use resistance training for them as well. Sorry, I didn't catch your second question. Can you repeat that?
Sure. What I asked is that if I am studying physiotherapy, would clinical psychology be a suggested pathway if I want to focus in psychology patients?
Okay, so let me repeat. So you are now a PT?
Yeah.
Student, and you want to be a CP?
Yeah, kind of. I just want to focus in the psychological aspect, but I'm not sure which pathway would be more beneficial for psychology patients.
For patients, you mean?
Yeah.
I think both. Because Okay, so we are talking about the patients with psychological problems. So we always focus on the psychological symptom. But we also notice that in clinical practice, some patients complain of their physical problem, and they didn't realize actually they have psychological problem. Okay, so this is a very, so I would say the whole body are connected. So either PT or CP, I would say both will help the patients. And I would recommend you to combine both for your career to treat a person. So we look at the person as a whole, but not as partly. Okay, so you know what I mean.
Thank you. Thank you so much.
I would like to add a little bit for the student who raised this question is that now when you are going out and work in psychiatric setting, and most of the time we work as a team. Now it includes physiotherapists, occupational therapists, clinical psychologists, and social workers as well. All right, so as a physiotherapist, you can also work and contribute to the treatment of those with psychiatric disorders. All right. Okay, so we now welcome the next question. Now, according to the screen I read, the next question goes to Wong Oiling. So you want to raise the question yourself, or you want me to read it out? Now, if you want to ask the question yourself, you can just show up with the video. Wong Oiling. No response. Now, if no response, I just read it out. Now, the question from Ms. Wong is that, Jessie, have you recorded any brain activity when patients are having aerobic exercise and yoga during the experiment?
This is a very good suggestion, but we didn't because we use Fmri. You know, it's a very big machine, so we cannot send them into that when they are doing yoga or exercise. Yeah. But I think this is also I'm going to do is that to wear some equipment like EEG. So EEG cannot. Maybe Fmri. I don't know. So when they are doing some intervention and you record them at the same time. So this would be a very good suggestion for us to consider. Professor Chen, what do you think?
Oh, yes. I think what you did is very good. I think in Hong Kong it's very pioneering. But MRI or functional MRI has the limitation that is, the patient has to lie down and go into the big machine. And is Yvonne Han here? Yvonne Han. Now Yvonne is also our colleague, and she is an expert in FNIAs. So we are now exploring some kind of portable and wearable device while people are doing different kind of motor activities. So I think you can join our group and see whether we can understand the brain, and while people are doing different kind of motor activities or mind-body exercise. I think this is the way to go. All right. Okay. And of course we are looking forward to the future MRI machine, which is terrible.
Yeah, I'm so looking forward to that.
We have to wait. All right, so then the next question. So who would like to ask the next question? So according to the screen is Tam. So who, I cannot read very clearly the name. So it is, Jessie, the question is that it is proven aerobic exercise have good impact on structural changes of brain and yoga, the function. Do you think combination of both therapies will have superior impact than individual interventions?
Yes, this is also, I think other research has already done is that they design a very comprehensive intervention program, which include the aerobic exercise for like 10-15 minutes, and then do some stretching. So they use the yoga posture to stretch, and then do some resistance training, and then do 5-10 minutes relaxation or something. So this is a very comprehensive program. We can do that, of course. Yeah.
Good. Okay, the next question is Frank. Frank, you want to ask it yourself?
Yes, thank you. Yes, thank you. Can you hear me?
Yeah, sure.
Oh, thank you, thank you. Thanks, Jessie, for your very excellent presentations. Congratulations that you show us that you did a very good job in the previous. I would like to ask for the study that you conduct, I suppose, in German. You mentioned something about exercise training, yoga, and the conventional therapy. Well, I would like to know how can you to ensure and to measure the compliance and adherence of subjects amongst all these different types of interventions? Thank you.
Okay, thank you, Professor Lem. This is a very, very good question. I would like to share with you that actually the attendance is not so ideal. Okay, so we suppose the patient can attend 70% of the session. So we have 3 sessions. I'm talking about the yoga exercise study. We have 3 sessions per week. 12 weeks is 36 sessions. And the average attendance is 50%, half. So only 10 to 20 patients completed all the 36 sessions during the 12 weeks. And most of them can only attend 1 to 2 times per week. So most patients can attend once per week. That's no problem. But twice a week, like half, yeah. And 3 times a week, very, very few patients. So yeah, we record their attendance, and we have case manager for each patient. And the case manager will contact them during the week and to remind them to attend the session. And also we have the carer, so the caregivers. And we allow the caregivers to do exercise with the patient together when they're in the study. So this is the, of course, we pay them the traffic allowance. So this is all the ways we want to improve the attendance. And but as we observe that, so first, randomization into aerobic exercise and yoga will lost some participants, and because they want to choose exercise but not be randomized. This is one issue. And the second issue is that really depends on the motivation of the patients. So for those patients which I mentioned before, that they didn't want to do any exercise at all, so they will be out of our study. So this is the limitation, that there is some I would say sample bias. Yeah, so when we recruit the patients, they all have the motivation to do some exercise. But we observe that because of the illness or the medication, the motivation somehow is not so good, not so ideal as we expected. Yeah, so but in mindfulness-based intervention, we got a very good attendance. For both psychosis patient and the postpartum woman, we got 80% attendance. And especially for the postpartum woman, so this is also, we didn't expect, because you know the mothers should be very busy, and we expect they can attend half. That would be very good for us. But we observed that those mothers can attend 80%. And half of them completed 8 weeks, complete eight sessions. But the reason is that mindfulness-based intervention only 1 time per week. But aerobic exercise, we said 3 times per week. Yeah.
All right. Okay. Very, very interesting discussion here. All right. Okay. The next question goes to Sonata. So Sonata, I think you should voice out your question yourself and introduce yourself to Jessie. So Sonata, where are you? Are you here?
Hannah. The microphone of Sonata got some problem.
All right, okay, so I read it out for her then. All right, okay, Sonata is our associate professor, and she is also doing research on exercise, but more with the animal rather than clinical studies. So Sonata has a question for you, and she said that you have done a very nice work, and and he said that it is very interesting for you to find out the different pattern being activated by yoga and aerobic exercise. Your study found that activity of the precuneus region involved in attention is suppressed by yoga in psychotic patients, but not aerobic exercise. So she would like to have your comments on if this brain area is specifically affected by yoga. Aerobic exercise involves muscle movement that can trigger lots of myokines secretion and metabolic hormonal secretion. And this hormone can directly act on the brain function. So your comment, please.
Yeah, thank you. Actually, the question is somehow overlap with Professor Chen mentioned. So, yes, so aerobic exercise activates the muscles more than yoga, but from our study, the imaging data showed that it's not specific area activated by yoga, but a network. So we observed that there are some areas, so not only one area, there are some areas, including the prefrontal lobe and the parietal lobe, and also some area in the precentral gyrus. So it looks like doing yoga can activate several areas of the brain, but not specific one area. This is what I also talked about before, that yoga may not increase the metabolic, but it really stimulates the neuron in some areas and make them communicate with each other more. So that's why we see a connectivity in the brain, but not the single area. Yeah, am I clear with the question?
All right, okay, so yeah. Sonata, if you have further questions or response, you may type it out. All right, so the next question goes to Ali Tan. Now, in fact, I do not quite understand your question. Would you mind to speak up? Ali, are you here?
Yeah, I'm here.
Yeah, okay, so you better you speak up your questions.
Thanks, Jessie. The study is very interesting. And also on the topic about the aerobic exercise and the yoga, I think the aerobic exercise you're using is some of cycling and treadmill running. But I'm thinking about the yoga that involves some concentration aspect. And what if we have some aerobic exercise, sporty like exercise that require higher concentration? Maybe interesting to see what is the effect of this sort of activity or exercise on the topic you are studying. And also about the yoga, you mentioned you chose the hatha yoga. And we know that the different type of yoga, they make some kind of yoga, they have higher energy and movement or different forms like that. So maybe they have different effects. So this over study may provide us more information. I think this is the area maybe we can see.
Thank you so much, Ali. You raised a very important comparison with yoga aerobic exercise. It's dancing. So I know Professor Rainbow Hall at Hong Kong U. Professor Chen maybe know her as well. She did many study of dancing because dancing is a kind of aerobic exercise, but with many body coordination. So it's like high skill aerobic exercise, I will say that. And dancing movement, so first it's aerobic exercise, and the second it really requires the coordination. So I'm not sure if maybe simple dancing can be used in the patient with psychiatric disorder, but if we see with psychosis patient, especially the chronic psychosis patient, dancing will be very difficult for them. But okay, so I agree that for different patients we can use different intervention, and I will mention here that dancing movement really is really effective for the patient's perception, and also for the motor learning, and also for the mood symptom. Yes, it's effective. And you mentioned yoga with a high energy level, so I know what you mean. You mean the flow yoga. So I know there is a flow yoga, and or vinyasa. So this is can raise the heart rate. Oh, okay. So I forgot to mention, when we did aerobic exercise for the patients, we measure the heart rate. So every patient will wear a heart rate measure. It's a belt. So they will wear to the belt, and we control the heart rate to reach 75% of the maximum heart rate. So which is moderate intensity. Okay, so yoga, I mean the flow yoga or vinyasa. So this is can reach the heart rate to almost to moderate level. And this type of yoga also can be tested, but I didn't do this yoga for the patients. And also, again, considering of the patient's physical standards, and they may not afford the flow yoga or this kind. Yeah, but I think this is a very good direction to think about it, and maybe for other population, I would say, yeah.
All right. Okay.
Thank you.
The next question is again Frank. But Frank, would you mind we give priority to those who have not asked their first question? Is that
Yes,
okay?
sure.
So now, if this is the case, the next question will be from a participant called Yi Chung Hua. And I think you are asking about the validity of functional MRI data. You want to ask it yourself? Li Chonghua, are you here? Now, if not, then I'm asking it for you. Now he's I don't know whether it's he or she. Now this participant, cited a study from Duke University, and he said that they just released a report saying that functional MRI is not so accurate, and provide different readings for the same person doing the same task just a few weeks apart. So I think this participant is facing doubt about the reliability of functional MRI data, and this person also want to ask, according to your experience, is there any other way to look at brain activities or the areas affected that is even more reliable and valid than functional MRI?
Okay. So functional MRI, so the mechanism is that it actually not measure the activity of the neuron directly. So it's measure the change of the blood flow. So that's why, yeah, I know someone will argue that it's not so stable because blood flow can change always. Yeah. So first point I will point out is that for our patients, we compare between groups. So which means that we compare baseline and the 12 weeks between 3 groups. And we compare yoga with control, aerobic exercise with control. So if there is any unstable signal, I think when we compare different groups, so it will not have an effect on the results. Okay, so yeah, everyone has the chance to have unstable signal. I mean, if we compare group to group, so this maybe can be ignored. Okay, so this is first.
Yes, yes,
and,
very good.
Yeah, and the second you mentioned the other way to measure the brain. So as I know that, MRI is the one choice, and also the other option can be EEG. But EEG, the temporal and the spatial resolution, I would say is okay. So MRI would have better spatial resolution, and also it's a new technique I heard is from Professor Zheng is Fmri. So Professor Zheng maybe, but I have no experience with Fmri or EEG. Maybe Professor Zheng will say something about that.
Now, this is not my area. I'm just starting to try to adopt this kind of measurement, and I know that it has one thing that is better than functional MRI is that people can move around and do any kind of motor activities when the research participant is wearing this portable device. So I think this is much better than functional MRI that allows the patient to do things, and rather than just lie down and do some kind of cognitive activities. All right, but I know that some people in this department are doing the research using FNIRS. So and that is why I would like to invite Yvonne Han again. Yvonne, are you here? Now, if not, then now don't worry. It will take turns to her to present her work later on. I think David Mann will be doing this kind of arrangement, and at that time we try to let her know about the query among some of our audience that have these questions, and ask her to compare the pros and cons between FNIRS and also functional MRI, and see whether she has any good comments on that. Now, in fact, time is up. Now, Fang, do you really want to ask the last question, or you want to ask Jessie later on?
I will approach Jessie for further discussion with my questions.
Because time is already up, so I would like to summarize by just talking about two observations. I am very happy and also very surprised today. Now, first of all, is by the number of participants, and now is dropping down to 105. The highest is over 200. Maybe people have to get back to their work. So it means that online seminar is even better than face-to-face in a way, because a lot of other people can join while they are having the lunch time, even at different settings, and they have no time to travel to PolyU. And the second thing is that I'm really very happy to know that we have a niche area in mind-body intervention, and I'm very happy that Jessie deliver a presentation in a way that attract a lot of people from our department and also the students to have interest in this area. So thank you, Jessie. I think it's just the beginning. All right. So I think you will be. I hope that you will be having a good time. Doing research along this line of your study, and I think it will act and contributes a lot to we have intervention in the future. And I know that you are from a medical background, but as I said, for the treatment of psychiatric disorder and likely other, disability, and we rely on teamwork. So I think your experience and your expertise in the future will work with, our OT and PT to come up with, something even more innovative than what you are now doing. All right.
Sure.
So I think we have to end this session, although I'm quite sure some of you still have questions. But Jessie will be here, and she will be full-time working in RS. So if you have any questions you want to discuss with her, you just send her email, or when the pandemic is further slowing down, you're welcome to come and see us and have discussion with us anytime, all right, about your query and also your research interests, all right? Okay. So you have a last word to say, Jessie?
Yeah, thank you so much, Professor Zheng, and I'm looking forward to meeting you in person. Yeah, all of you.
All right. Okay.
Thank you.
So thank you very
Fran.
much for joining this very, very informative seminar. So have a nice day. All right. Bye-bye.
Bye.